Good morning everyone. So in this next series of lectures after the metallic instruments, we will be discussing the non-metallic instruments, or rather drains, tubings and other plastic items that are used in the surgery department. So we will be starting with some tubes. So first of all, we will see how the Foley's works and what are the parts of a Foley's catheter. So analyzing the parts of a Foley's, we can see there are two types of Foley's. This is a two-way Foley's and this is a three-way Foley's channel. So this is the main channel at which a Eurobag is connected. This is the side channel through which the normal saline, we will see how the normal saline is pushed into this channel so that the balloon here inflates and it becomes a self-retaining catheter. There is an opening on both the Foley's at the tip here and here, as you can see, to drain the urinary bladder. So this is the opening. So we will now see how this side channel works to inflate the balloon. So we will take normal saline in this and we will insert the syringe in the side channel and fit it properly. And as soon as we will push the normal saline, you will see the balloon will start inflating. As you can see, the balloon starts inflating. So now nothing will come out of this. So this becomes a self-retaining. So we will inflate the balloon once the Foley's is inside the bladder. So if we pull it out, the bladder neck will hold this balloon and it will not come out. And the tip, this tip with this opening will remain inside the bladder, so that the urine will enter this tip and come out through this main channel and finally into the Eurobag. The same, now we will take out the normal saline from this. So as you can see, the balloon gets deflated. Now the same holds true for this tri-way Foley's. So as soon as we push the normal saline in this, so you will see that the balloon at the end gets inflated. Now here is additional channel in this for some surgeries like transurethral resection of prostate, in which continuous irrigation is required so as to prevent the clot formation due to the bleeding. So here additional drip set will be connected through which irrigation will continuously go into the bladder like this inside the bladder, and the clot mixed urine or the normal saline mixed urine will come out through this main channel into the Eurobag. So this is used for additional surgeries like transurethral resection of prostate. Now coming on to some things that are written on the Foley's, we need to understand. As you can see, the 16, this 16 denotes that the size of this Foley's catheter is 16 and the color that corresponds to 16 French Foley's is orange color. So the color coding you can see in my book also. So for different sizes of Foley's we have different color coding. Now the second thing that is written is 5.3 mm. This is the diameter of the Foley's that is written over there. And the third thing that is written is 30 to 50 ml. That means that this Foley's can accommodate a maximum of 30 to 50 ml in its balloon during inflation. Normally we insert around 10 ml of normal saline in this, and in this 30 to 40 ml depending on the bleeding that we expect during TURP surgeries. So coming on to the uses of these Foley's catheter, basically it is used for acute urinary retention, so to relieve the bladder pressure. Next, in critically ill patients, it is also used to in ICU to monitor the urine output of these patients. So coming on to our next catheter, this is also called as condom catheter. It resembles the shape of a condom. So this part just folds over the penis like this, like a condom, and this part is used to connect to a Eurobag, and this is the adhesive tape. In case this condom gets loosened over the penis, we will put an adhesive tape to just put a firm grip over the penis. So it is mainly used in patients with urinary incontinence or in those patients in which we don't want to put Foley's for a very long time. So this is a condom catheter. So coming on to our next tubing, that is called as knee latent catheter. So as you can see on the back of the tubing, we have this mentioned. It is a 14 French catheter which corresponds to the green color of the tubing, and the diameter is 4.7 mm. So this also has a color coding for different sizes of the knee latent catheter, which starts from 6, 8, 10, 12 to up to 24, which has different colors which can be seen in my book. So the uses for this knee latent catheter is for short term bladder catheterizations. It has two openings on its end which can go inside the bladder and drain the urine. This is a wide end that is connected to the urobag. So the next use we can use also to dilate partial urethral strictures. So this is a Yonker suction set with a long handle. It has a plastic tubing. It has two ends, one of which gets connected to the suction machine and the other gets connected to this plastic cannula like this. Whenever we switch on the suction machine, it has a small covering here which is used to control the pressure of the suction with our thumb, and this tip has an opening which is used to suction out the contents like pus and blood and fluid from our operative areas. So now we will see parts of a central venous catheter. It has a pack like this which has things like syringe, one guide wire. This is a central venous catheter which can have this 1 port, 2 port or 3 port. This is the needle, this is a dilator, and these are the suture wings to secure its position. So we will see how this works. What are the uses? So the main use is to monitor the parenteral nutrition and also to measure the central venous pressure of any patient. Also we can administer chemotherapy drugs, or it can also be used for frequent dialysis. The common sites through which this can be inserted are the internal jugular vein, right or left, subclavian vein, right or left. So first I will show you, we connect this syringe to this needle after filling it with a certain amount of saline like this. Then we will insert this needle in the patient wherever we need to, in the subclavian or the internal jugular vein, the procedure of which is mentioned in my book. As soon as the blood comes out of this syringe, we will disconnect it and secure its position by our thumb and index finger. The blood will keep coming out from here. Then we will take the guide wire, remove its cap like this, and we will insert the guide wire inside this, and as with the help of our thumb we will push the guide wire and it will come out through the opening. As we can see, it is coming out through the needle. So as soon as this will go inside the vein, we will secure this guide wire over the skin and pull out the entire structure out of this. Now the next part is to dilate the skin. So keeping our hands still, we will insert a dilator like this. So suppose this is the skin. So we will maneuver the movement like a screw movement and dilate the skin so that the central venous catheter goes easily through the skin, and take it out like this. Then we will take the central venous catheter and like this, we will push it over the guide wire and push it inside the patient's body like this. So when the guide wire comes out through this opening, we will finally pull out the guide wire and this end will be secured inside the vein. After securing it inside the vein, we will use these two things to fix it over the skin like this, and this over this. So this will lock, and these two holes we will take a suture on both the ends from the skin and secure this so that it does not get pulled out from the skin. So now we will discuss some tubings. First of all, we will discuss Rice tube, that is also called as nasogastric tube. So as you can see, this is a 1 meter long tube like this. This end has a lead bead which is detectable on X-ray, and this line, this orange line that you can see, this line can also be detected on a X-ray. This end is used to connect to a urobag. It has two lids. First lid can be closed like this, and through which a syringe like this can be fitted so as to put some content inside or aspirate some content from it. And if you have to completely close the tip, then we can put this small cap over this. It has several openings through which either feeding can be done or suction can be done through the stomach. And these are the markings like this: 50 centimeters, 60 centimeters and 70 centimeters marking. So, these marks basically denote at 50 centimeters usually the Reyes tube is present in the body of the stomach. At 60 centimeter usually it is present at the pylorus of the stomach. Normally we fix the Reyes tube at this marking only. So, there are several indications of this Reyes tube. There may be diagnostic, therapeutic or for feeding purposes. Diagnostic, we normally put a Reyes tube through our nose and do a gastric aspirate for different studies. In therapeutic, we normally use to decompress stomach, and during perforation peritonitis cases or any other cases when we need to decompress the stomach or the small bowel, then we put in a Reyes tube so that the contents come out and the bowel and the stomach decompresses. And the third purpose is the feeding purpose. In patients those are comatose or in patients that are not able to take oral feeds, we put in a Reyes tube and do a Reyes tube feeding through this opening so that the contents can directly go to the stomach. So, we will come on to the next tube, that is also called as the infant feeding tube. That is very similar to the Reyes tube, except it is very smaller in size and of a very smaller diameter, usually used in the pediatric age group of children. It also has openings like the Reyes tube. It does not have a lead shot at the end. The other opening can be connected to the urobag or can be used for feeding purposes. This black mark is usually present at the 20 centimeter mark. So, I will show you how to measure the amount of length that can be put in the pediatric patient. So, on my face, this is a tragus and this is our angle of mouth. First, we will measure the distance from tragus to the angle of the mouth, and then we will measure the distance from tragus to the xiphisternum. We will add both these values, and this will be the value at which the Reyes tube needs to be fixed at the nose. So, that will we will measure it like this. So, this will be the tip will be inside the stomach, especially for the pediatric age group. These two lengths need to be collaborated. Next, the uses are same as Reyes tube. It can be used for therapeutic purpose. You cannot take out anything from inside the gastric by gastric lavage. You can put anything inside it, that is, it is used for the feeding purposes. It is also used for decompressions during several surgeries or in intestinal problems or in obstruction cases. So, we will connect it to the urobag. This can also be used for urethral catheterization, because in pediatric age group the penile urethra is very narrow and such fine tubing can only go inside the pediatric urethra. Thank you. So, now our next tubing is the Kehr's T tube. It is also known as T tube because of its shape. These are the T, and this is the horizontal limb of the Kehr's T tube. This is the vertical limb of the Kehr's T tube. It is actually long. We need to get both the ends. It is used in surgeries mainly related to the CVD, like cholecystectomies or in CVD repair. Whenever we do these things, we put in a T tube. These horizontal limbs are placed in the proximal and distal part of the CVD, and this part comes out through the abdominal wall outside, and it drains the bile to the outside into a urobag, through which we can measure the bile output, etc. After 7 or 8 days, or some people prefer 2 weeks of surgery, if we need to do a T tube cholangiogram, we push the dye through the external limb. This is the vertical limb of this. The dye will go inside the CVD on both sides, and we will see, and we will take our X-ray and see if our repair has been successful or not, or whether the stone that was taken out has properly been taken out, or there are some remnants of the stone or not. So, this is the Kehr's T tube. So, the next tube is a flatus tube. It is a very thick tube made of rubber. It has a big opening on this side and a lateral wall opening also, and a very big opening on this side. It is a bit of conical end. So, what we do is when we need to pass the when in post-operative period, if the patient is not passing flatus or in some problems like sigmoid volvulus, we lubricate this end, and with the help of our finger we insert it perrectally and pass it distally, so that the pressure or the gas that is present in the sigmoid colon comes out through this end. In cases of sigmoid volvulus, sometimes the sigmoid volvulus gets resolved if the flatus tube is able to pass through the kinking junction, and this is normally not used these days, but it was very frequently used in the previous days for this purpose. Tube. We will first see what are the parts of a tracheostomy tube. So, it has an outer tube, this, and an inner obturator, also known as introducer, this one. The outer tube has two wings that helps to secure it in place. The obturator has a small round tip that facilitates its entry into the trachea. These tubes may be cuffed or uncuffed. I will show you. This one is a cuffed tube. So, this is a one-way air entry valve. If we push air into this balloon will inflate like this, which will secure its place inside the trachea. This will also inflate and will show, because this will only be visible outside and this will be inside the trachea. So, if this is inflated, correspondingly this will also be inflated. We can pull the air out and the cuff gets deflated. So, similarly, there are other tubes that have non-cuffed tubings. Then this is a suction tube that is connected to the tracheostomy, in which we can do suction while the patient is on tracheostomy tube, and there is a small opening here through which the suction works. Then, as you can see, there is this blue line is a radio opaque line through which the position of tracheostomy tube is confirmed in patient with the help of an X-ray. And this obturator, I will show you how to insert this obturator inside the tracheostomy tube, outer tube. So, it will insert like this, and as you can see, this blunt tip will come outside this. So, whenever we are inserting this tracheostomy tube inside the trachea, this blunt tip will facilitate its entry into the trachea, and as soon as it's entered the trachea, we will take it out and inflate the bulb. The full procedure can be seen in my operative steps videos. Now, how to connect these straps to this? I will show you one. So, these are the threads that are provided with the tracheostomy tube. We will put out this thread like this and take it out like this. So, this will be one and the other will be like this. So, when the tracheostomy tube is in place, with the help of these threads, it will be tied around the neck to secure its place. So, normally tracheostomy is done in cases of maxillofacial injuries, in which oropharyngeal airway cannot be placed, orotracheal airway, or in patients with low GCS, in which we need long-term invasive airway. So, in those patients we prefer tracheostomy to put them on ventilators. Now, moving on to the transurethral dissection set, that is also known as TOR set. It has a Y-shaped limb. These two limbs get inserted into normal saline bottles, usually 3-liter normal saline bottles, one each, and these are the locks through which we can lock, and we can open either of the limb if we want to enhance the normal saline flow. Through this limb, there is another lock here. We can block the whole flow like this, and which will come out through this end. This end will be connected to the endoscopes or the TOR set, wherever, or the suction, laparoscopic suction, wherever we want to connect it. So, now moving on to the ADK drain kit, that is also known as abdominal drain kit. So, we can see this is a plastic bag with markings present here, starting from 25 ml to 2 liters maximum capacity. This is the outlet through which we can empty the bag. This is the handle through which it is hung on the bed side, and this is the tubing through which there is a connector that we connect like this, and this is the actual drain that is placed inside the abdomen. It has markings starting from 2 to 20. We can use it till any length. These are the atraumatic eyes that is placed inside the abdomen, through which the collection goes through the tubings and comes out through this area. Then through the connector, it is connected to the bag like this. So, this is the whole system. So, this ADK drain kit is mainly used in abdominal surgeries. Normally, we place two drains, that is one is subhepatic drain and the other is the pelvic drain, to monitor the collection in the post-operative period of the patients. So, now we will study about the Romovac suction drain set. So these are the parts of a Rumovac suction drain set. We will first see this is a bellow unit with a connector, and as we can see, I'll tilt it to show you the markings present here. So the markings will start from this 50 ml at the bottom and 800 ml maximum. So whenever there is a collection in this, we hold this bellow unit in a horizontal position and see the collection corresponds to which mark. In this way the collection is measured through this bottle. Next part is a connecting tube, this with a Y connector and a clamp. This part will be connected to this end. The next is a curved needle. This is a curved needle with a matching catheter. There are aromatic eyes, very fine eyes at the end of this. We can cut it if we want, if we don't want eyes till the very end of this tubing. And this is a spare perforated catheter which can be connected to the second Y shaped this. So this will be connected like this. This end, when we will take out the needle, will be connected to this part. This will be connected to this part. Usually this is this type of drain is used in surgeries that we commonly put in subcutaneous planes, like modified radical mastectomies or in incisional hernias repair, so that if there is any subcutaneous connection, that comes out through these tubings. So I'll show you how to connect this to this, so that we create a negative suction pressure for this. So when we put these tubings, and we have to press the bag like this, so that there is a negative suction created in this bellow unit, and we'll connect it here. So when these eyes will be inside the skin, then it will create a negative pressure, and these two tubings like this will be connected to the Y connectors like this, and the whole collection will come out through this. When the collection will increase, this bag will inflate automatically, and then we can measure the collection through this bag. So now moving on to the intercostal chest drain set, I will show you. These are two types of intercostal chest drain, ICD drain. One is the ICD with a metallic trocar, one is ICD without trocar. So in this, there is a protective cap like this, and there is a metallic trocar, which if we pull out, this tip goes inside the plastic tubing, and this comes out through the plastic tubing. There are 8 traumatic eyes at the end through which the collection from the thoracic cavity comes out, and their markings 5, 10, 15, 20. Similarly here also 2 to 20 centimeter markings are present, which helps us guide that how much of this drain is to be inserted into the thoracic cavity. So for to insert this thing into the thoracic cavity, we first place the trocar inside the tubing and gently push it in a screwing movement like this, and once it enters, the collection will come out through this tubing. We can see the blood or something coming out through this tubing. So we'll just rotate its direction and try to insert in the posterior medial to keep our direction of this trocar in a posterior medial direction of the patient. As we enter the thoracic cavity, we'll just pull this tip out so that it does not cause any trauma to the lungs, and we'll push this tube further over the metallic trocar, keeping it in the position. As soon as it reaches around 15 centimeters, we will take the full metallic cannula out after clamping the tube like this, so that the air does not go inside the cavity. This part would have entered the thoracic cavity, and we will then connect the feeding then ICD bag to this thing. In cases of this without a metallic trocar, we will place a artery forceps around this, and in the similar fashion, we will take with the help of artery forceps, we will enter inside the thoracic cavity and push it in the posterior and medial direction, so that it goes behind the lungs, and will drain the collection in a similar fashion. We will then cut this tip from here and place a connector here, and this will be connected to the ICD bag again. These tubes are normally placed in patients with hemothorax, empyema, or trauma patients with pneumothorax. These are very helpful, and normally in trauma patients, these are surgical emergency in which we need to place the tubes in acute emergencies when the patient comes to us. So this is a corrugated drain. It has corrugations present in this, so you can see the shape. These are the corrugations present in this drain. So these drains are normally placed in the hydroceal surgeries, through which the collection can come out through the scrotum through these grooves, and we can cut these corrugated drains in any shape or design that we want. And normally it can also placed in subcutaneous position during after laparotomies. But the major disadvantage of this drain is that it does not provide a closed system and can cause secondary infection. So after this thing, now we'll move on to different type of drip sets that we used during our medicine and surgery wards. So I'll show you. We'll first start with the pediatric chamber. So I'll show you the parts of a pediatric chamber. So this is a pediatric chamber with the capacity that is mentioned here, that is 110 ml. These are the two ports. This one is the injection port through which any injection can be inserted inside this chamber. This is the air vent. This chamber vent, if we can open this, it will allow the air to enter inside this chamber. This comes in various sizes like 110 ml and 150 ml. Now, as you can see, this is the Murphy's chamber, and you can see the metallic piece inside the Murphy's chamber that creates micro drops. In this, 1 ml is equivalent to 64 drops. Now, these are especially used for neonates and infants where strict monitoring of IV fluid administration is required. So, now this is the tubing, and we can control the drops by this regulator. We can close it like this and open it like this, and through this the fluid will come out. So, I will just demonstrate how to connect this to a normal saline bottle. So, we will take this out. The sharp needle will go inside the normal saline bottle. First, we will lock this so that it does not come out instantly. So, this we will pierce it through this inside the bottle like this. So, as you can see, this drip set, it fills this Murphy's chamber, and this pediatric chamber fills, and this is the marker, so that we can see this blue ring, so that we can see what amount of fluid is inside this chamber. Like it is 10 ml right now. So, we can increase. Now, if we press the Murphy's chamber, we will see that some amount of fluid comes through there. And now, if we'll hold this like this, and if we open this, you can see micro drops falling inside the Murphy's chamber like this, very fine. So, these 64 drops will constitute of 1 ml, and this fine fluid, I will show you. We will have to increase the rate for like this. So, now it has become to the it has gone to the full rate, and it will come out through the tubing. So, you can see the fluid moving through the tubing like this, and finally, it will come out through the outlet like this, like this. So, again we can control the flow that is coming out through the outlet with the help of this knob. So, now coming on to the IV drip set, you can see its part. This is the spike that goes inside the IV fluid. This is the air vent through which the air enters inside the drip chamber or the Murphy's chamber. And as you can see, there is no metallic tip inside the Murphy's chamber. So, it is a normal drip set in which 1 ml corresponds to 10 drops in this, and this is the plastic tubing. This is the control knob with which we can control the flow of the fluid by moving it down. This stops, and we can increase the flow by moving it up. And finally, the fluid comes out through this, which is connected to the IV cannula. Normally, these are used to administer IV fluids to the patient. So, now we come on to the blood transfusion set. As you can see that there is a filter in the Murphy's chamber. This filter that filters out any clots that are present during the blood transfusion. It has a small sharp needle that is used which inserts inside the blood bag, and there is a similar tubing inside this, and this is the flow regulator by which we can control the flow of blood moving into the patient's body, and this is the end through which the blood comes out, and normally it is used for blood transfusions. Chale? So, this is a scalp pain set. We can see it is also known as a butterfly cannula. These are the butterfly wings, and this needle is a siliconized needle, and it is used to give short term fluid administrations or draining out the blood from any vein, and it is normally used. This is also called as a trivic cannula. It is also called a lever lock stopcock. it has markers over it, 3 wings. So these 3 ports can work together, any 2 can work together. So I'll show you how it works. So we'll open all the 3. This end is connected to the IV cannula and these are connected to the drip sets. If these 3 arrows are in this direction, this will not work. This will stop, and the fluid coming from this will go inside the vein. If we move it like this, so the this port will stop now, and the fluid going through this will enter inside the vein. If we move the cannula to this direction, then nothing will go inside the vein, and the fluid going inside this will come out through this port. So this is how it works. So we'll now see some kind of bags that are used in general surgery practice. One of it is a Euro bag. So this is a Euro bag. It is usually used to measure the urine. It can measure urine ranging from 100 ml to 2 liters. This is the outlet through which this bag can be emptied, and this is the handle through which it can be hanged on the beds, and this is the plastic tubings through which it is connected to the Foley's catheter outlet. So now we will see, this is a feeding jejunostomy bag. This is the cap of a feeding jejunostomy bag. So I will show you. We can open this feeding jejunostomy bag and put the contents that are meant for feeding jejunostomy or rice tube feeding, etc. inside this. This is a plastic bag with a 1200 ml capacity. So in this we can use pulse water, normal water or coconut water, etc. or any liquid thing that needs to be administered. This is the lock, this is the chamber, and these are the tubings. This is the knob to control the flow, and through this end it comes out. It is connected to the feeding jejunostomy tube or the rice tube, from whichever mode we want to give it to the patient. So it is normally used in cases of feeding jejunostomies, or we can connect it to the rice tube for this rice tube feeding, or we can connect it to the gastrostomies. So it is a multi-purpose use. So now I'll show you the ICD bag. So this is a ICD bag with the underwater seal system, and there is a marking which shows the initial water level. So we need to fill initial water level up to this marking, so that the tube with a hole inside gets submerged in the water to create an underwater seal. Through this we can put normal saline, or through this we can also empty this bag. This is for bed hanger, and this is the tubing that is connected to the intercostal chest drain tube. So whenever the air or the fluid, anything comes out from the ICD tube, it goes inside the water and will fill the bag, but no air can enter inside the water as the hole is submerged inside the water here. So this is the ICD bag. So now I will show you the parts of an intravenous cannula. First, this is a lever lock. This chamber is also called as the flashback chamber. This is called as the needle grip. This is the injection port through which any injection can be administered. There is a valve here that is present in this part. Then these are the wings of a intravenous cannula, and this is the needle that is present inside the catheter. So I will show you how to assemble this. So this is the catheter. We will put the needle inside the catheter, and the sharp end of the needle will come out through the plastic catheter. We'll put the cap, and now I'll show you how to hold this. So we'll hold the wings by index and the middle finger, and the thumb finger will be put here, and we'll make the vein, and we'll insert that. I have made another video for intravenous cannulation, and we'll insert the catheter. As soon as we see the blood inside the valve, then we'll withdraw the sharp end of this needle. So the plastic cannula will be there, which will be non-traumatic. Then we'll push this cannula inside the vein and secure its position. We'll take out this cap, and we'll cover this plastic cannula with this cap and put the tapings to secure its place. Now at the end, I would like to give you a brief introduction to the sutures, the details of which can be seen in the book. I will show you some of the different sutures that I have displayed here, and how to read the contents that are written on the back of a suture. So first I would like to focus on this suture. So like this is the trade name of this suture, Vicryl, and the compound that is mentioned here is polyglactin 910. This is the size of the suture is 20. The length of the suture is 90 centimeter, Coming on to the details of the needle, it is a 31 mm half circle needle with a taper point. It can also be a round body needle, and the circle can be, this is a half circle. So now coming on to the next suture, we can see this is a nylon suture, also known as ethylon, and the compound is polyamide. This is a 2-0 suture with a 45 mm 3/8 circle reverse cutting needle. So you can see the shape of a needle also is resembles a 3/8 of a needle, and this is non-absorbable. This violet color is a proline suture, that is a non-absorbable suture, and the compound is polypropylene blue suture. 2-0 is the size, 31 mm half circle, taper point is the needle. Now coming on to this, it is a monocryl suture, monofilament, So coming on to this, it is a monocryl suture. It is a monofilament polygrecoprone suture with a 70 centimeter length. Its needle is 26 mm 3/8 circle conventional cutting needle. Now coming on to this suture, this is a polysorb braided absorbable suture, just like Vicryl, and this is a half cutting. This is a half with a 26 mm cutting needle. Coming on to the next, it is a bone wax. Bone wax is usually used in amputations where we need to put this wax on the ends of the bone to prevent the bleeding from the marrow. Then the next is a chromic suture. Chromic is a absorbable suture. This is also known as catgut because it is derived from the catgut and is preserved in a sterile fluid. Its size is 2-0, and this is a 30 mm half circle round body needle. It is usually used where we need a very less strength of the tissues. Next is the Mercer suture. It is a non-absorbable braided suture. This size is 3-0. The needle is 20 mm half circle round body needle. It also comes in taper cuts. All these sutures come in different numbers, ranging from number 1, then 10, then 20, 30, 40. As the number increases, the thickness of the suture decreases. The suture becomes more fine. Next is again a Mercer suture, that is non-absorbable suture. 20 is the size, and this is a round body half circle 30 mm needle. So these are the sutures, brief overview. For the details of these sutures, we'll have to refer to the book for the details of these sutures. Thank you.